عبير. صباح الخير. الحقيقة الدكتور حسام قال بعض الحالات اللي هي ممكن تظهر معانا فهيسهل عليها الأمور في بعض الإمرجنسيز. This is our agenda for today. Actually, the abdominal emergencies can be classified according to the age. In the neonatal period, we should think about the NIC, perforation, atresia, meconium ileus, plug syndrome, meconium plug syndrome, Hirschsprung disease, volvulus. In infants and toddlers, the intussusception, HPS, foreign body, Meckel's, bowel duplication, basal pneumonia. For school children and adolescents, of course, appendicitis, ovarian testicular torsion, gastroenteritis, cholecystitis, and pancreatitis. The imaging modalities in the neonatal period, we depend really on plain X-ray of the abdomen. So you should have an approach to look at the abdominal X-ray. I invented this approach, which is called DNA approach, okay? Don't forget the DNA approach. D stands for dilatation distribution of bowel gases, N number of dilated bowel loops, and always remember that number 3. A stands for air and ascites. Starting with the D, which is dilatation, in the neonatal period, we go to L2 vertebral body, and we should measure the interpedicular distance. If the bowel diameter is equal to or more than this distance, you diagnose dilatation, okay? And for the distribution, actually in the neonatal period, we can't differentiate between the small and bowel loops because the baby does not form or develop hostra in the colon yet. So we can use the horizontal beam. The colon is usually located dorsally, while the small bowel are usually located ventrally, and the colon has this long air level. N, so we finished D, now N. N, number of dilated bowel loops. If it's 3 or less, you mean, or in that case, you may diagnose high obstruction. If it's more than 3, it's low obstruction. A stands for air. We look at air in the rectum. You should decide if the rectum has air or not. And we look at the air in abnormal locations, like bowel loop, like the portal tracts, like the under the diaphragm, to diagnose perforation. Now, the other A is the ascites, okay? In the plain X-ray, you can predict ascites if it's large amount of ascites. In that case, you have a distended belly with a soft tissue, central location of the bowel loops. You go for ultrasound to confirm the ascites. In neonate with an acute abdomen, usually presents with vomiting, constipation, distension of the belly. When the symptoms are present immediately after birth, the most common cause is GI obstruction. And here are the classification of the obstruction. High obstruction, starting from the esophagus till the jejunum. Low obstruction from the ileum to the anal atresia, and the acquired diseases, as I mentioned before. This is our first case, a premature neonate with abdominal distension. Now, D, dilatation. N, number all. Okay, A, air in abnormal location. As you can see here in the portal tracts, under the diaphragm, and ultrasound also, you can appreciate here some air foci within the bowel wall. So this is a typical case of NEC, and prematurity is a must. And when you have acute abdomen in a neonate, you should look for perforation. Here are some signs of perforation. That's called the football sign, which is an air in front of the liver. This is the falciform ligament. You see it because it's surrounded with air. Okay. Other findings here, you see a regular sign, air surrounding the wall of the bowel loops. And in that case here, you see the continuous diaphragmatic sign. You see also the inverted V sign, which is called T sign, which TL sign. This is because there is air surrounding the whole bowel loops. This is for further reading. It's a nice poster located here, if you wanna go. Now, let's go to our next case, double bubble. So you know that's less than 3, okay, so it's high obstruction and typical for jejunal atresia. This is 3 dilated bowel loops with the horizontal beam. You can appreciate the jejunal loops, frontal orientation, so this is jejunal atresia, okay, an innate with abdominal extension, high or low, low obstruction because many bowel air fluid levels, okay, and in that case with the enema, you can see normal sized colon but dilated small bowel loops, and this was a case of ileal atresia. In that case here, you see also dilated bowel loops, but you see micro colon on the left side and many filling defects within the colon as well as the distal ileal loops. So this was a case of meconium ileus, and of course it might be associated with cystic fibrosis. In that case, this is a case of midgut volvulus, innate with bilious vomiting. So this typical corkscrew, and as Dr. Hussam said, this is what's the whirlpool sign. whirlpool يعني دوامة, okay? So this can be seen with CT. In intestinal malrotation, presentation mostly before 1 year of age with midgut volvulus. These are the risk factors: congenital diaphragmatic hernia, heart disease, omphalocele. Treatment is surgical. Prognosis is bad if it's associated with volvulus, okay? And ultrasound has a role in its diagnosis, especially in case of malrotation, as I will show you. This is case presented with Dr. Hussam. I will not go through it. This is HPS. Okay, and of course, ultrasound is the modality of diagnosis. 3 millimeter and 15 millimeter are the numbers you should remember here. Okay. Now, our next case, a 2-year-old male child with acute abdominal pain. Name the sign and what's your next. This is the sign here. What's this? This soft tissue with crescentic appearance of the bowel loop here. That's called the half moon sign. You suspect intussusception. Next step is ultrasound. This is bowel within bowel. The donut sign with the transverse image, while the pseudo-kidney sign with the longitudinal image. So the intussusception is usually presented at 9 to 24 months. These are the risk factors: viral gastroenteritis, rotavirus vaccine, metal duplication, lymphomas, cystic fibrosis, and so on. Treatment could be hydrostatic rheumatic reduction. Prognosis is excellent. And of course, ultrasound is the modality of choice, but can be also diagnosed with radiography, fluoroscopy for therapy, and CT. A case 8, a 15-year-old girl with ingested tongue pierce. البنات اللي بيركبوا البيرس في لسانهم. This is bad, منتشرة قوي وبتجيلنا في الامرجنسي روم انها بلعته. Take care. Of course, lateral view if the foreign body is located in the esophagus is essential because it's located posterior to the air-filled trachea, so you know that this is in the esophagus. What's this? Chain. When you see this chain, this is magnet, okay? Ingestion of magnet is an emergency and surgical emergency because coins usually pass safely, but magnets and batteries are complicated with bowel ischemia and are considered surgical emergency, should be removed at once. Now we go to appendicitis. Common commonly seen in the ER. How to diagnose appendicitis? We go at the level of the iliac vessels, that's the iliac artery and vein. This is the normal appendix, so diameter should not exceed 6 millimeter. This is the transitional zone, that's the dilated appendix containing debris fluid level, okay, as seen here. So, okay. Sometimes we go to CT if you have abnormal location, like in that case, subhepatic appendicular abscess. With the coronal formats, you can see the appendiculus, you see fluid-filled appendix, you see here also surrounding the appendix this dirty fat with fluid surrounding it. I would like to add something here about the technique of CT. You should give oral as well as intravenous contrast to look at the enhancement of the wall and to separate the appendix from the contrast-filled other bowel loops. Okay, children younger than 14, slight male predominance, and in second decade of life. Risk factors, non-specific, obstruction of the appendicular lumen with lymphoid hyperplasia. Of course, the treatment is surgery and with excellent prognosis if you do the diagnosis in the right time. MRI has a role in, an excellent role in assessment of appendicitis, but unfortunately, it's not convenient in the pediatric age group. Here are the ultrasound signs of acute appendicitis: tubular structure with no compressibility, lack of peristalsis, transverse diameter equal to or greater than 6 millimeter, wall thickness greater than 2 millimeter, loss of wall layering with wide hypocac appearance, inflammatory changes in the surrounding mesenteric fat, and distension of the appendicular lumen. This is a male patient with right iliac fossa pain. We found this abnormality here, might be appendicitis, but it's crucial to locate the normal appendix in that case. So this is a case of Meckel diverticulum, and you know it's Meckel by presence of blood cells in the stool. Okay, so this is Meckel. What's the difference between this case and the other case? When you see this cystic structure surrounded with all three layers of the bowel and communicating with the lumen of an adjacent bowel, so this is a duplication cyst. This, of course, ovarian torsion, usually seen at the onset of reproductive years, and here are enlarged edematous ovary with peripheral displacement of the follicles, presence of twisted vascular pedicle, absence of flow, suggesting infarction. MRI could be reserved for complicated or question cases. Now let's go to some quiz cases. This is a baby with acute abdomen. Can you pick the abnormality? Here is the abnormality here, okay? So dilated bowel loops, obstruction, and there is bowel here gas in the left groin. This was a case of incarcerated inguinal hernia and could be confirmed with ultrasound. What's this one here? So this is typical case of Hirschsprung disease. And remember that the normal ratio between the rectum and sigmoid should be more than 1. In that case, it's less than 1. So this is typical. خلاص. Okay, the types of Hirschsprung disease, we have the short segment type, which is more than 75%, long segment 15%, total clonic gangliolosis 8%, and ultra short segment, that's the least one. Can you pick up the abnormality here? It's difficult. Yes, this one here. So that was an appendiculate, could be stone, and in that case, ultrasound will solve the problem. So what's your diagnosis here? Don't forget this also. Okay, this is a case of hematometra. Okay, now let's go to the section, last section of our lecture for today is what's the difference. I will put 2 images and you diagnose the difference. Coiling of the nasogastric tube in both, that one gasless abdomen, that one with gases, so this is esophageal atresia, and the other one with fistula. What's the difference? Double bubble, duodenal atresia, but you don't see gases beyond the level of the duodenum. But in that case, you see few gas bubbles, so that one is web, the other one is duodenal atresia. And of course, you can confirm that with fluoroscopy. What's the difference? This one here and those there. In that case, you see small colon with filling defects at the distal ileum. But in that case, you see the filling defects are located in the colon, and which shows a small left side colon. So this one here is meconium ileus, that one here is meconium plug syndrome. What's the difference? This is ingestion of foreign body. And look at the shape of the foreign bodies here. That one is homogeneous. This one has halo ring sign. So this is coin, that's battery. Okay, which one is more dangerous? Of course, this one. And the battery, look, this is the battery. It looks the same here, double wall. Okay, what's the difference? This, which one is normal and which one is abnormal? Okay, in that case, this is a case of normal orientation of the vessels. You always see the vein at the right side of the artery. These are mesenteric. And most importantly, the distance between the mesenteric artery and the aorta is filled here with the structures. That's the uncinate process of the pancreas, and this is the third part of the duodenum. In that case, in malrotation, you see abnormal orientation. The vein is at the left side of the artery, and diminished distance between the artery and the aorta. Okay, you don't see any structure here. So there is malrotation. Duodenum did not pass in between. So this is very important, and you can diagnose it with ultrasound easily. Okay, malrotation, normal. What's the difference? This is testicular ultrasound. That's the normal. This one is edematous, lack of blood supply. So this is testicular torsion. And finally, what's the difference between all lines and the tube? You should be able to recognize them. This is the endotracheal tube. That long one here, which ends at the stomach, is the nasogastric tube. This one with these plastic lids are the ECG, okay? Trace it. This is ECG electrodes. Here at the level of the umbilicus, you see two catheters. The one passing through the liver here or across the liver, this is the umbilical vein catheter. That one here is the umbilical artery catheter, okay? In conclusion, don't forget the DNA approach. This is my invention, modestly, in a neonate, so to diagnose obstruction or perforation. Ultrasound is the modality of choice in HPS, intussusception, appendicitis, torsion, stones. Gastrographene studies may be used in Hirschsprung disease, some types of atresias, and midgut volvulus. CT and MRI are reserved for complicated or problem-solving issues. Thank you.